Dear audience, I am pleased to find myself in front of you today to present you the progress attained over the first 9 months of my PhD thesis titled New Insights Upon Adverse Events of Statin Treatment. About myself, my name is Tudor-Cristian. I'm part of the bilateral PhD program, which takes place in cooperation with the University of Pharmacy and Medicine in Iași. My supervisors are Peter Ferdinand, Renata Pap, and Ionela Lacrimera Șerban, and my trustful SMS is Amir Makoni. Well, the vision I arrived in Budapest was clear, that is to provide prolonged, healthy, and independent lives for the elderly. However, in order to achieve this, my team and I have to fulfill a pretty difficult mission, that is to conduct evidence towards disentangling the ways common medication impacts the musculoskeletal system. These are the 3 specific goals I started this year. The first 2 will be realized under the systematic review and meta-analysis procedure, while the last one will involve a retrospective approach. Let me introduce you to the first project, tightly related to my vision, titled Investigating the Effects of Statins on Development of Sarcopenia. Co-investigators involved in shaping this project to life are Victoria Barna and Bertalan Tordai. Some background information. So, sarcopenia is more than just the accompanying term near every description of elderly population. In fact, sarcopenia, according to 2018 guidelines, is defined by 3 low pillars. That is, low muscle strength, low muscle quantity or quality, and low physical performance. But what is the connection between statins and this sarcopenia? Well, first of all, the number of people who are recommended statins is continually growing by the ever-aging trend of population and by the very strict cholesterol guidelines, which by 2018 recommended more than 20% of population to take this treatment. And also there is a plethora of mechanisms supporting the solid evidence in the reports which state that statins sometimes elicit very severe muscular symptoms. Therefore, it is our mission to demonstrate whether there is a significant association between continuous statin use and sarcopenia, or statin adverse effects are limited to just muscular symptoms. To achieve this, we employed the clinical question, does statin therapy increase the risk of sarcopenia in adult population? We employed the PICO framework, where the population was limited to adult age. The intervention was statin treatment compared against not statin treatment, and the outcomes of interest revolved around quantifiable parameters related to sarcopenia. And our hypothesis is that treatment with statins is safe regarding the risk for sarcopenia in adult patients. The search key was elaborated using 2 limiting domains. In the intervention, we included only statins still in use, and outcomes included every single quantifiable, that is measurable, parameter, including in ASPEN or ASPEN current guidelines. The initial rather impressive number of more than 17,000 hits dropped to only 78 articles, eligible articles, 63 of which could be used for meta-analysis calculations. We are now in the figures and tables elaborating phase and risk of bias assessment, as you can see in this figure. First important plot of this study concerns the comparison between statin-treated group and not statin-treated group by means of 6-minute walk test. What this test is a non-specific, straightforward approach of measuring the progression of sarcopenia, which involves measuring the distance covered by a patient at their normal gait speed over the course of 6 minutes. The lower accepted, very dependent on age, weight, comorbidities, the lower accepted limit of this 6-minute walk test is around 400 meters in most studies, and the minimum difference attained during a procedure which accounts for clinical significance ranges from just shy of 15 meters to just over 30 meters. In this figure, you can see 25 studies, 25 different populations coming from 23 different studies, accounting for more than 7,800 patients. We included 12 cross-sectional studies and 11 trials, and the heterogeneity therefore is very high, not only due to the studies design involved, but also the different magnitudes of effects. The overall effect is 12.67 meters in favor of the statin-treated group. That is a trend towards better outcomes using statin treatment, but this effect, due to the defining of minimum clinically sound difference, does not nearly attain clinical significance, and the statistical significance, again, does not reach. Seeing the rather different magnitudes of effects in the previous plot, we performed subgrouping by means of chronic comorbidity, chronic major comorbidity, that is the chronic disease that puts the patient at risk for sarcopenia in spite of any other type of treatment. As you can see in this first part of figure, none of these subgroups yield negative outcomes with statin treatment, none of them. Concerning the apparently healthy population in this last part of the figure, you can see that the effect is varied, is heterogeneous, but there is no statistical significance of it. Therefore, we can safely assume that statin treatment is safe regarding 6-minute walk test. This is the plot comparing, again, the same statin-treated versus non-statin-treated groups concerning short physical performance battery, which is a test, an objective test, which assesses simultaneously the balance function, gait speed, and ability to rise from a chair objectively. The test takes values from 0 to 12. Normally, it takes a value of 12, and anything starting from 11 and below has a significant meaning of sarcopenia, and any difference for an intervention which can attain clinical meaning is of at least 1 point, because again the test takes integer values. The overall effect in this plot with 8 different populations from 6 different studies is 0.47, which attains statistical significance because the confidence interval is on the right half of the axis, but the clinical significance is limited by the defining of the values of this test, again, integer values. Again, statin treatment is safe regarding SPPB. Let's move now on to the second project of my thesis, titled Assessment of the Efficacy and Safety of New Antidiabetic Drugs on Improvement of Inflammatory Profile. Regarding background information, by 2021, almost 500,000 people were affected by type 2 diabetes, and this number is expected to rise to up to 1.3 billion by 2050, and the bulk of it will be represented, as you can see in the figure, by the age range 75 to 79. Therefore, at such an advanced age, cardiovascular protection should be focused upon mitigating inflammatory stress. This inflammatory stress is the culprit for two complications in this age range, two very often encountered complications, that is chronic heart failure and blood vessel rigidity. GLP-1 agonists, employing several pathways, act upon inhibiting the inflammatory stress through the common mediator, that is inhibition of nuclear factor NF-κB. SGLT2 inhibitors similarly act at several sites inside and upon the cell, again leading to the same inhibition of the common mediator NF-κB. Again, inflammatory stress is the effector and mediator and catalyst for undesired modifications, not only limited to the cardiovascular system, but the whole body. Therefore, it is our responsibility to find the most efficient therapy and the safest in order to provide the patient the best standard of care. We employed again the PICO framework. We limited the population to adult age patients with type 2 diabetes mellitus. The intervention will be represented by new antidiabetic drugs, that is GLP-1 agonists and SGLT2 inhibitors, against placebo. The outcomes of interest revolve mainly around inflammation, major adverse cardiovascular events, and lastly, traditional cardiovascular risk, but above all, quality of life improvement, because this is what we want to assess. Our hypothesis is that treatment with new antidiabetic drugs leads to a reduction in inflammation and better quality of life. In summary, these are the 3 projects. I plan to submit the first one in September 2025, and the other ones 1 year apart. I would like to end my presentation with my favorite quote, that is, the road to success is always under construction. And thank you very much for your precious time.
Thank you very much. Questions from the right side.
Hello, thank you for your perfect performance. In your first project, second figure, 6 minutes walking test,
yes,
you mentioned apparently healthy population.
Apparently healthy, yeah.
What does that mean?
Okay. No individual who takes statins is in fact healthy, because statin has to come from a recommendation, that is improvement of lipid profile or any other approved and understood pleiotropic effect. Apparently healthy means an individual which does not fall into the chronic comorbidity categories that we define. That is, as you have seen on the slide, COPD, chronic heart failure, HIV, any kind of chronic disease with a longer evolution that puts the patient at risk of inherent sarcopenia, aside from any drugs that we would treat the patient with.
Thank you.
So regarding your third project, which will be about patients who underwent COVID infection, can you please offer more insight why this research will be novel? What novelty can you add more to the available literature?
Yes, you are right. There is a bunch of literature existing. These parameters, these hematological index-derived parameters, but these articles have not yet employed a machine learning algorithm and have focused on very strict characteristics of defining the population that they included. From the discussions we've had, we will adapt this model to the Hungarian population, but the idea is to allow the machine learning model to be used by other communities of researchers. That will be the novel aspect of our study.
Tudor, excellent presentation. Even though we're in the same group, it's my first time seeing your plots and nice results. I was wondering, you had one plot with limb amputation for the 6-minute walk test. So I was wondering, how do they walk the 6-minute walk test? And is it reasonable to compare it to the apparently healthy population if they had limb amputation before?
Yes, that was an actually difficult question when we performed the analysis, because in the limb amputation group, the test was performed over the course of only 2 minutes using walking devices they would need, because of course different amputation types from below or above the knee would need different kinds of devices. So this will be a limitation. We transformed by tripling from 2-minute walk test to 6-minute walk test, but we can perform the overall analysis because we compare mean difference. We do not want to see the absolute value, but the mean difference between statin treatment and not statin treatment. We are not interested in the baseline value, only the difference between these two groups. So despite the limitation that the test was performed over a shorter period of time, the significance is kept.
Okay, so it did blend in with the other results,
yes,
and it doesn't significantly affect you.
And did not even behave like an outlier, exactly.
Okay, thank you so much.
Please explain this to me. So you were in the first project, you were comparing those who were taking statin versus not taking statins for how long?
This is excellent. This is excellent. So a reason for the heterogeneity, as you precisely figured out, is the time interval that they were taking statins.
Okay.
In the 11 trials that we included, we know for how much time they were taking the statins. But in the cross-sectional ones, in only 2, we know the minimum time that they were taking statins, while in the other 10, we just know that at the time of analysis, they were prescribed and were actually taking the pill. For how long, we cannot know.
And do you have any kind of data that would compare population at one time and follow them up until like few years later and see how their 6-minute walk test differs, and then look for patients who are taking statins in the meanwhile and not, because people age during the meanwhile. So I don't know what the age group were and if you adjusted any of this analysis for the age differences, but that's a huge difference. And obviously those who are taking statins would probably be in a different age group than those who are not taking statins, because they are not at any risk factors.
If you allow, I know this is not very professional, but I would like to return to a plot, because it's exactly what you asked. It will be this plot. If you can see in the first study in the chronic heart failure group, the first one seems like an outlier. And there are several reasons for it, which you might have guessed. Yeah, the age is different between statin and non-statin treated, and people who are taking statins were older, significantly, statistically significant older. They were more frequently diabetic patients, and the degree of chronic heart failure assessed by NIHA, the classification, was higher. So aside from this study, every other comparison did not return statistically significant age differences. So apart from Correale, every other population was uniform comparing statin versus non-statin. Across different studies, yes, there are variations from 35 years old to up to 85. So the magnitude of effect is different, but I believe that the original aspect is pulling together and trying to account for the factors.
Okay, thank you so much, Tudor.